day, ladies and gentlemen, good day, colleagues. Thanks a lot for Dr. Yahya for the kind invitation and possibility to present my lecture, my little presentation about the newborn asphyxia and new methods of the treatment. Because all we know that severe asphyxia has absolutely different impact on their neurological outcome. Therefore, this is not a lecture about their presentation, about their treatment. This is a presentation about their science, because I present my data that I founded in Department of Pediatric Research in Oslo University under supervision of very famous person, Professor Ulla Saugstad. Unfortunately, sadly, he didn't come. Okay, I did not have any conflict of interest and try to understand what in different opinions of their persons of the science, what does it mean, just asphyxia, perinatal asphyxia. American Academy of American Academy of Pediatrics, American College of Obstetrician and Gynecologists recommended that term of perinatal asphyxia be reserved for newborn infants with a low ABGA score. It's clear, but it comes only in 1992, not earlier. But the question of the cerebral palsy, some neurological disability, the people knew from long time. Nevertheless, other recommendations, a little bit more epidemiological data, will give us the World Health Organization. Due to definition of this organization, birth asphyxia is failure to establish breathing at birth, accounts about many deaths. But I would like to pay your attention not only what we do, because we discussed it many times in the first day on the workshop when we discussed about their NRP. I would like to follow for the last question. Whose work includes, monitoring and data, guidelines, quality of care, and research. Very good question. It's very difficult to research severe asphyxia of newborn. It doesn't matter in what country we live, because we have a lot of restrictions. But we can try to understand what we have just now. Due to my personal search in different sources, PubMed gave us information that newborn asphyxia treatment and different type of medications, we can choose for more than 1,000th time. Cochrane Library give us only 8 reviews, asphyxia and resuscitation. I couldn't jump to their PubMed because we spent a lot of time, it's really. But Cochrane Library will be much helpful. Anyway, what we know and what we have. We have whole body or craniocerebral hypothermia for newborns with HIE. This is our standard. And we know about different methods, medication and gases, different type of trials, and different types of lab studies. But nevertheless, we will jump once more to their Cochrane Library. It's a very famous result that we have evidence in more than 10 randomized controlled trials included in these systematic reviews. And of course, we have a good proof that hypothermia will be helpful for newborns with severe asphyxia. Yes, it works. We can go. What we know about many types of experimental therapy, we know that we have antioxidants. We can use anti-inflammation and antipsychotic medications. We can use trophic support, and we had tried to use regeneration. And all of these methods, all of these medications and gases, information about them you can take from the PubMed and other sources. Nevertheless, what we really used just now, Cochlear told to us that unfortunately we don't have any conclusion about erythropoietin. We don't have any conclusion about melatonin because they have only the protocol and no any other words more. Some words about their stem cell-based therapy, but unfortunately no evidence. What we try to do, we try to jump one more slide and try to understand what we have, what kind of physiological, pathophysiological reaction we will see in the hypoxia. First of all, we will see that oxygenasis of perinatal hypoxic ischemia brain damage is complex. It's very important, complex. It's not only the failure or injury of the brain. This is a complex of different reaction. And we try to use medication or equipment or tool that can prevent this injury. This is very, very important. One more about what we have and what we would like to have. We have hypothermia only, but it works in 100%, I think no. Sometimes works very well with very well neurological outcome, sometimes no. Therefore, we try to explain what kind of medications, what kind of drugs can we use for their severe asphyxia. Why my interest was noble gases, xenon and hydrogen? Because during maybe the last 50 years, these two gases is actively researched on the basis of the neuroprotection. The first studies about hydrogen was from 70s of the last century, and it was about the tumor of the liver. Afterwards, it's a cascade of different neuroprotective strategies, but unfortunately, animal strategies or cell strategies were used with xenon and hydrogen. I tried to compare in very simple basis, color, heavy, non-heavy, odorless. One very, very important thing. We must know that hydrogen very cheaper versus xenon. Xenon is really very, very expensive gas, and we can't use it for many, many times. But some anesthesiologists used it in operation room. One more science, one more physiology, pathophysiology about their noble gases about xenon. How it works? It performs neuroprotective function by binding of their NMDA, because the glutamate is the main neurotransmitter of the central nervous system. You must know and please follow for this gas. Hydrogen has a lot of effects. Anti-inflammation, 1. Antioxidative, 2. Anti-apoptotic, 3, and etc., 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 etc. Why we can't use it? It's very easy. It's cheaper. It has a lot of effects that we can use for severe asphyxia. Try to understand. Maybe not very nice slide. I'm sorry. This is a brief database, what was done with the xenon. And if you look attentively, only couple of, just wait, yeah, couple of, I'm sorry, couple of data from their neonatal hypoxic ischemia. This data from the cell and mice study. Okay. Some time ago, it was very nice research in the United Kingdom, and one pilot study, maybe not pilot, maybe control study, was done in the different hospital in the Great Britain. But what was the effect? What was the result? Result was that the administration of xenon within the late time frame used in this trial is feasible and apparently safe, but is unlikely to enhance the neuroprotective effect of cooling after burst asphyxia. In the other words, yes, it has a lot of effects that we need, but unfortunately, it doesn't work. It doesn't work. Similar slide with their analysis. And if you will see, only few studies about neonates in mice and in pigs. In my institution in Oslo, in Department of Pediatric Research, we perform a model of their newborn pig and try to understand, does it hydrogen will have anti-apoptotic effect? This is very important because we presumed that if the gas is cheaper, if the gas can be used in delivery room, why we can't try and perform this study and to analyze. This is only the hypothesis. This is only not what we can do in realistic. We took huge number of their animals and divided all animals in 4 intervention groups. First of all, the standard care room air. The second group is hydrogen group. And of course, we know that hydrogen plus hypothermia, we hypothesized, will have more interesting effect, we have a more strange. Therefore, we combine room air plus hypothermia, and the fourth group, hydrogen plus hypothermia. Try to find superiority. What we will find with a known and unknown type of medications, type of their treatment. And of course, we have a very small 6 animals in the control group. This is our experimental protocol. If you will see that all newborn pigs were delivered in a medical institution early morning from the local farm. They were weighted, anesthetized. We make intubation. We inserted the intravenous catheters. We inserted intra-arterial catheters, especially to measure blood pressure and to take their blood samples. It was a big work. Nevertheless, due to our experiment, we try to mimics asphyxia with their carbon dioxide. And afterwards, we follow for their reaction. We try to reach 2 points, or blood pressure will be less of 20 millimeters of mercurium, or base excess will be the same or less, minus 20. Immediately, when we reached this goal, we stopped the severe asphyxia and started to treat due to our design of the study with room air or with hydrogen for 30 minutes. And what kind of results we have? We, after 9 hours of observation, we terminated all peaks from all groups, snap frozen all tissues, brain, eye, liver, and many, many others. And afterwards, we try to research. The research is ongoing. Maybe we will have more interesting results during the times, but now I can share with you only what we have by now. We try to research caspase expression in prefrontal cortex in these groups. If you will see that, yes, the model is still working because in the control group expression of caspase is lower than in the group of investigation. And we see that there for room air plus neonatorum plus compare with our hydrogen plus neonatorum, we will see the difference. Try to go more in the statistics because we need statistic for statistical difference, not only for the words. In our conclusion, in our results, sorry, caspase-3 expression was significantly lower in both groups receiving hydrogen compared with their room air with the standard care group. There was not significant towards reduced of caspase-3 activation in hydrogen plus hypothermia compared with room air plus hypothermia group. The analysis of caspase-3 positive cells did not show significant difference between group receiving hydrogen followed by neonatothermia and hypothermia. In the other words, we suppose it's only theory that our data indicate that resuscitation with hydrogen gas may not have, but may have an antipoptotic effect on the cortex after severe asphyxia. Whole body hypothermia could enhance the influence on hydrogen gas. Of course, we need more data from the research. Of course, we need more data from the tissue because we try to research not only their brain, but liver, lung, and urine in different laboratories. It will take a time, but nevertheless, it's our first, maybe not very prompt, but interesting result. What kind of advantages and disadvantages we have in the lab studies? The first of all, we try to mimic pathophysiology of the disease. Research different types of pathological reaction in different cells, tissues, and organs, and must predict and translate in the clinical medicine, in the practice. This is our main goal. Try to do something interesting, to find something interesting in the lab study, and try to use it in the practice, in everyday practice. But what is the main disadvantage, sorry. Not all experimental models work similar. We can't compare, for example, monkey and pig. We cannot exclude mistake in the hypothesis and the design of the study. It's time consuming, and of course, it's expensive. It's very expensive. This is my comments, my personal comments to the end of this presentation, that we can't use experimental unproved methods, unproved data in the delivery room and dental ward. We must be accurate in interpretation of all experimental data. In the other words, to have a criticism, but we need to have the new method, new treatment, new medication to prevent severe asphyxia. And must think not only to treat, because this is not only our task, but to think about their follow-up, high quality of the life. In the other words, we don't have the magic bullet for the hypoxic ischemic injury, but we try to reach their goal, and science will help us. Thanks a lot for your attention.